Good morning, everyone. The topic for today is chronic rhinosinusitis and its management. Myself, Dr. Ganesh, Assistant Professor, Department of ENT, Sri Lakshminarayana Institute of Medical Sciences, Puducherry. So, the content of this class would be definition of sinusitis, classification of chronic sinusitis, etiology, pathophysiology, clinical features, fungal rhinosinusitis, diagnosis of rhinosinusitis, treatment options for rhinosinusitis, complications, and recent advances of in the management of chronic rhinosinusitis. So, moving on to the definitions. Rhinitis is nothing but inflammation of the lining of the nose. Okay, as you all were aware. Then we have sinusitis, which refers to group of disorders characterized by inflammation of mucosa of the paranasal sinuses. Whereas rhinosinusitis is nothing but inflammation of lining of the nose and paranasal sinuses. So these are the three different terms and terminologies and definitions used interchangeably during a patient who has been treated with chronic rhinosinusitis. Scope for chronic rhinosinusitis. Why we need to know about this chronic rhinosinusitis? It affects almost approximately 13% of population in the United States, that is almost around 31 million people. The prevalence is similar to that of hypertension and diabetes. Most common reason that individuals seek medical care is chronic rhinosinusitis. They spend more than 2 million per year worldwide. The amount of money which has been spent for treating a patient with chronic rhinosinusitis is averaging almost around $2 million per year. Moving on to classification of chronic rhinosinusitis. It is classified into allergic, infection, and others. In the allergic category, we have intermittent chronic rhinosinusitis. Allergic rhinosinusitis, which is intermittent, which is otherwise called as seasonal. Patients who have this seasonal rhinosinusitis, they have this seasonal exacerbation, especially during your winter and rainy seasons, and they'll have waxing and waning courses. Then we have the second variant, which is called as your persistent allergic rhinosinusitis, which is all through the year, perennial, which is running all through the year. Coming to the infective part, infective rhinosinusitis can be acute infections or acute rhinosinusitis. Then the other spectrum is the chronic rhinosinusitis. We have one more variant, which is called as acute exacerbation of chronic rhinosinusitis. Then the third broad category is others, where we have occupational exposure or rhinosinusitis secondary to occupational exposure. Then it stands for non-allergic rhinitis with eosinophilic syndromes. Then we have hormonal reasons, drugs, irritants, food materials, emotional disturbances, atrophic rhinitis, gastroesophageal reflux disorders, or sometimes the etiology is unknown, where we call it as idiopathic rhinosinusitis. Coming to the classification, where we have acute rhinosinusitis. The rhinosinusitis where the duration of onset is somewhere less than 7 days to less than 4 weeks of duration. Then we have subacute rhinosinusitis, where the duration will be from 4 weeks to 12 weeks. Then we have the third variant, which is called as recurrent acute rhinosinusitis, which is nothing but the rhinosinusitis which is there for a period of more than 4 episodes per year. Then the last spectrum is the chronic rhinosinusitis, where we have sinusitis existing for a period more than prevalent for a period more than 12 weeks, which is called as chronic rhinosinusitis. Then acute exacerbation of chronic rhinosinusitis. This is sudden worsening of chronic rhinosinusitis with return to baseline after treatment. This is called as acute exacerbation of chronic rhinosinusitis. This classification system was given by Rhinosinusitis Task Force of American Academy of Otorhinolaryngology and Head and Neck Surgery, RTFA. Okay, this is what is the classification. So we have acute, subacute, recurrent acute, which is more than 4 episodes of acute rhinosinusitis per year. Then chronic rhinosinusitis and acute exacerbation of chronic rhinosinusitis. Anatomical classification. Based on the 4 paranasal sinuses which are involved, it can be classified into maxillary sinusitis, sphenoidal sinusitis, ethmoidal sinusitis, and frontal sinusitis, depending on the anatomical region or the particular sinus which is involved. It is classified into maxillary, sphenoidal, ethmoidal, and frontal sinusitis. Sometimes we have a last variant which is called as pan sinusitis, which is self-explanatory. Moving on to the etiology. Extrinsic causes. Infection, usually viral, bacterial, fungal, and parasitic infections, play a major role in the development of chronic rhinosinusitis or acute exacerbation of chronic rhinosinusitis or recurrent acute rhinosinusitis. Then the non-infective etiology or inflammatory etiology, we have allergy, which is IgE mediated predominantly. Then we have non-IgE mediated hypersensitivities, pharmacologic agents, irritants. These are the reasons for inflammatory causes. These are the inflammatory causes for rhinosinusitis. Then we have disruption of normal ventilation or mucociliary drainage, which is predominantly by surgery. Okay, functional endoscopic sinus surgeries or infections or in the form of trauma, especially your maxillofacial trauma, which may occur, which may hinder the drainage of the sinus, leading to development of rhinosinusitis. Intrinsic causes, we have genetic etiology, where there is mucociliary abnormality, especially your cystic fibrosis or primary ciliary dysmotility syndromes. Then on the structural etiology, there is some gross septal deviation with spur, or there is presence of double middle turbinate, or there is presence of accessory ostium. All these things are reasons for the development of chronic rhinosinusitis. Then we have immunodeficiency. Immune deficient adults, as you all know, is very susceptible to various infections. Sinusitis is one of the infections. Then we have few acquired conditions, especially aspirin hypersensitivity. Aspirin hypersensitivity is associated with asthma and nasal polyposis, which is called as Samter's triad. Then we have autonomic dysregulation. Then hormonal rhinitis of pregnancy and hypothyroidism. They all have been postulated as the development of reasons for the development of chronic rhinosinusitis. On the structural side, you have neoplasms arising from the maxillary sinus or frontal osteomas or ethmoidal sinus malignancy. All these things will obstruct the flow of sinus pathway, leading to stagnation of sinus fluid, leading to development of sinusitis. Osteoneogenesis, especially patients who have been on osteoporosis or osteomyelitis of this region, will have neo-osteogenesis, which leads to development of sinusitis. Retention cyst and antroconal polyp has been postulated as the other probable etiologies. On the autoimmune or idiopathic side, we have granulomatous disorders, where we have sarcoidosis, vaginous granulomatosis, or vasculitis, we have Chuck-Strauch syndrome. And immunodeficiency has been postulated as the reason. Moving on to pathophysiology. So what is happening? Basically, there is a bacterial infection. We'll start from this one. Whenever there is bacterial infection, what is happening? There is some mucosal thickening. Okay. Once there is bacterial infection, the sinus drainage mucosa will be thickened. So because this thick secretion is going and obstructing or going via the middle turbinate or middle meatal region, there will be ostium. The ostium around this middle meatal area will be closed. This closed meatus, what will it will do? It will lead to congestion of the mucosa or more anatomical obstruction. Then there is stagnation of secretion. This secretion again changes, or there is thickening of this secretion, leading to change in the pH, where it leads to mucosal gas metabolic changes. Once the gas metabolism in the mucosa changes, ciliary and the epithelium are damaged. Okay, this leads to damage of the cilia as well as epithelium. It creates culture mediums for the bacterial growth in closed cavity, which leads to retained secretions, which causes tissue inflammation. Tissue inflammation evokes bacterial infection. So this becomes a vicious cycle in the development of chronic rhinosinusitis. The role of bacteria in chronic rhinosinusitis. Usually, the upper respiratory tract serves as a reservoir. Establishment of correct microbiology is important, because sometimes there may be normal commensal flora which may be there. So the proper establishment of the causative agent has to be implemented, predominantly anaerobes. Okay, since there is obstruction, there is a drainage of the secretion, so there is a anaerobic activity which is going on. So we have predominantly anaerobic organisms obtain appropriate sinus content by either by sinus puncture or endoscopic cultures. So what are the normal nasal flora which is available? Until and otherwise you know what is normal, you can't say what is abnormal. So the normal nasal flora is comprised of Staphylococcus aureus, Staphylococcus epidermidis, alpha and gamma streptococcus, Propionibacterium acnes, or aerobic diphtheria, Prevotilla, Porphyromonas, then Fusobacterium. All these things are normal commensal bacteria which may be present in the nasal flora. What are the microbiology of chronic sinusitis, or what are the probable etiology for this causative etiology for this bacterial rhinosinusitis? It is predominantly by your Propionibacterium. On the aerobic side, we have Staphylococcus aureus, whereas on the anaerobic side, we have Streptococcus, which is the prime reason for development of sinusitis. Then Prevotella and Porphyromonas accounts for almost 47%. Then Propionibacterium acnes somewhere around 29 to 30%. We have Fusobacterium, which amounts for almost 17%, and bacteria, especially Bacteria fragilis, accounts for somewhere around 6%. On the aerobic side, apart from Staphylococcus aureus, we have Streptococcus pyogenes, which is almost accounting for 8%. Equally shared by pneumoniae, Marexella petralis, and Enterobiaceae by 6% on the snapshot. This by the study by Brook in the year 1981 and Erickson in the year 1966 and Feingold by 2002. So whenever we give antibiotic, a period of 12 days, say for example, Haemophilus influenza or your Mycobacterium catarrhalis, what after 12 days it will do? Again, they will have same infection, and which is superadded by Haemophilus influenza and Streptococcus. Again, you give for 7 days. Then what will happen? And if you can add amoxicillin with clavulanic acid, all the commensal, all the bacteria will get destroyed. Suppose if it is given for a period of 12 days. Suppose if we give amoxicillin alone for streptococcal pneumonia isolate for a 70, from streptococcus it is converted to Staphylococcus aureus, Streptococcus, and Prevotella. Again, if you are very much interested in identifying the same, then you can give ciprofloxacin. You can identify Staphylococcus aureus and Fusobacteria. Suppose if we give clindamycin, there is no growth at all. This is the spectrum or dynamics of sinusitis. So the take-home message over here is the arbitrary time limit for which the no growth has to be obtained, whether it is both aerobic or anaerobic one, is somewhere around 21 days. What are the clinical features of chronic sinusitis? The major and minor classification. Major classification includes facial pain and facial pressure. Then we have nasal obstruction, which has nasal intubation, nasal discharge, then discolored postnasal discharge, hyposmia, and purulence in the nasal cavity on examination. On the minor side, we have headache, fever, halitosis, fatigue, dental pain, cough, and ear pressure or fullness. So to diagnose it as chronic rhinosinusitis, we should have either 4 major and 2 minor, or 1 major and 3 minor. Okay. So facial pain and pressure is a major classification. Nasal obstruction again is major. Nasal discharge and nasal discharge and purulence is again a major criteria. Discolored postnasal discharge again a major criteria. hyposmia and purulence in the nasal examination. Once you identify the major criteria, the minor criteria includes headache, fever, halitosis, fatigue, dental pain, cough, and ear pain, pressure, as well as fullness. Coming to fungal sinusitis. The role of fungi in chronic rhinosinusitis is unclear. Primarily, fungal pathogens confined to three groups, especially zygomycetes, aspergillus, then dermatitious genera. In the dermatitious genera, we have bipolaris, helminthosporium, carvularia, crustulera, fusarium, cladosporium. Classification of fungal disease, we have non-invasive and invasive fungal disease. So we have sinus and fungal ball. On the non-invasive side, we have chronic or indolent invasive fungal sinusitis, allergic fungal sinusitis, and acute fulminant fungal sinusitis. So fungal ball is non-invasive, allergic fungal sinusitis is non-invasive, whereas chronic indolent or invasive fungal sinusitis is invasive, and fulminant fungal rhinosinusitis is again invasive. Coming to fungal ball, it occurs in adults. It is unilateral postnasal discharge, which may be seen. The radiological CT scan is helpful in diagnosis. Aspergillus is the most common fungal agent which has been aspirated. Surgical removal is the treatment of choice, and no antifungal therapy is necessary, especially in cases of fungal ball. Usually, it is Aspergillus which is the most common agent, and surgery is the definite treatment option available for removal of fungal ball. Moving on to allergic fungal rhinosinusitis. It is non-invasive. Dermatitious species especially are mostly responsible. 5 characteristics are seen. Eosinophilic mucus containing non-invasive foul-smelling hyphae. Nasal polyposis, characteristic radiologic findings, immunocompetence, and allergy. All these 5 characteristics is present. It is more in favor of allergic fungal rhinosinusitis. So we have eosinophilic mucus, nasal polyposis, characteristic radiologic finding where we have enhancement of the contrast or your density shadows, immunocompetence, and allergy. All these things are probable risk factors for the development of allergic fungal sinusitis. Pathology, you will have Coombs type 1, type 2 reaction. It evokes eosinophilic inflammatory response. Then there is obstruction of the sinus ostia. This ostia leads to stasis of secretions in the sinus, stasis of secretion in the sinus. This produces allergic mucin. Again, this exposes itself to fungal antigen, which is again responsible for development of Coombs type 1 and 2 reactions. So this is the pathophysiology of allergic fungal sinusitis. Moving on to chronic or indolent invasive fungal sinusitis. Its rare pathology occur in immunocompetent patient. Aspergillus mostly isolated. Maxillary sinus commonly involve chronic headache, proptosis, and cranial deficits are the etiologies for development of this chronic or invasive rhinosinusitis. Then treatment is combination of surgery and antifungal therapy. In this CT, we can see there is a complete the drainage of sinus inflow to the from the left maxillary sinus is affected. Then there is presence of optic eye changes. Okay, proptosis and cranial nerve deficits. Acute fulminant fungal sinusitis usually seen in immunocompromised individual, especially HIV and diabetes mellitus, or people who are on continuous chemotherapeutic drugs. Early diagnosis and control of primary is foremost important. Immunological function disorders are essential in the prognosis. On the diagnosis, we have nasal examination, endoscopy, and sampling and biopsy of the material. The sampling and biopsy of the material is just to understand the diagnosis. Extent of CT scan, the extent of sinusitis can be assessed by CT scan and MRI. Then surgery is by and antifungal during surgery. The antifungal agent is administered 2 days prior to the uh, removal. Then it will be easy for us to remove the sinus fungal ball in toto from the affected sinus. Osteitis in chronic rhinosinusitis, primary goal of surgical technique, Mersklinger and the primary goal of surgical technique is to re-establish the ventilation and drainage through the natural ostia. Even massive pathologic mucosal changes would be reversible. Histological studies include Norlander in the year 1994 noticed periosteal fibrosis, bone degradation, and new osteogenesis in rabbits after inoculation with Pseudomonas aeruginosa. So, osteitis is primary goal, especially of chronic rhinosinusitis, will be osteitis, but it will take some time. Okay, and even massive pathologic mucosal changes would be reversible, and histological variant was histological studies was by Norlander in the year 1994. Perloff and his colleagues in the year 2000 demonstrated the inflammation that could spread to the involved non-involved sinus. Khalid and the colleagues in the year 2002 demonstrated similar results in rabbits and infected with Pseudomonas and Staphylococcus aureus. There is a role for osteomyelitis and there is osteitis. Both goes hand in hand in the development of chronic rhinosinusitis. So we have osteoblastic activity as well as osteoclastic activity. Inflammatory mediators, prostaglandins and leukotrienes, they lead to osteoblastic activity, and there's formation of type 1 collagen and bony matrix, and there is osteoclastic activity which degrades this one, leading to a chronic inflammation which may present in the mucosa and the osteitis, leading to development of sinusitis. Implications for treatment: discourage the universal application of minimally invasive sinus technique. FIS with the complete removal of the bony partitions is better. So functional endoscopic sinus surgery is better rather than universal precaution of minimally invasive fungal clearance. Allergy and chronic rhinosinusitis. Various studies on the role of allergy in chronic rhinosinusitis has been done, but the precise mechanism which predispose the individuals to chronic sinusitis remains unclear. 3 criteria which should be met to support the role of allergy in chronic sinusitis are: patients who have chronic sinusitis should have a higher presence of allergy than patients who do not have chronic rhinosinusitis. Pathophysiological mechanisms between them should exist to explain the interaction. Treatment of allergy in patients with chronic sinusitis should improve or resolve the symptoms of chronic rhinosinusitis. So these are the 3 criteria. 1, patients who have been on a CRS for nasal drops, they should be seen by the ENT physician. Then on the second, pathophysiological mechanisms between them should exist to explain their interaction, and treatment of allergy in patients with chronic rhinosinusitis improve or resolve the symptoms of chronic sinusitis. Meta-analysis of various studies shows that there is high prevalence of chronic rhinosinusitis. Possible mechanism: increases edema, ciliary dysfunction, and increase mucus production, and neurogenic stimulation, and increase metabolic activity of the sinus mucosa. Treatment of rhinosinusitis. Senior and Kennedy, who has tried the surgical technique in the year 1998, and Dollar and colleagues in the year 2014. Then way back in 2004, Lund and colleagues were the first to use intranasal fluticasone to see the response of sinusitis. Diagnosis: specific objective, major and minor objective, which we have seen already. Physical examination and symptoms of rhinosinusitis. So excellent findings would be chronic swelling and edema of the maxillary sinus, ocular and the orbital area is B. Then we have anterior rhinoscopy where we can see hyperemia, edema, crust formation, purulence, polyps, and change in symptoms after topical decongestant application. So we have hyperemia, edema, and crust formation. Purulence on nasal examination is the major criteria in diagnosing patients with rhinosinusitis. So how will you go for endoscopy? You can go for rigid endoscopy or you can go for flexible endoscopy. In rigid endoscopy, 0 degree is used to pass the larynx, whereas 70-degree scope is used to pass, 0 degree scope is used for ear, 30 degree for nasal, this one, and 70 degree for your ear. We have also flexible scopes which are available commercially, which can be used to diagnose rhinosinusitis by endoscopy. Then moving on to nasal endoscopy, blue is discoloration of the turbinates. Blue discoloration gives rise to loss of functional problems over the corresponding sinuses. So, osteometal complex or sinus purulence is a feature. Then polyp formation, then septal deflection, concha bullosa, paradoxical turbinate, and other physiological or obstructive anomalies. So these are the various pictures where we can see final fungal sinusitis, the presence of purulence on nasal discharge, fungus which is coming out through the right maxillary sinus ostia. Then we have polyps, multiple punch of grape-like appearance seen. Okay, polyp formation. Moving on to the investigation, X-rays. X-rays will show like this, where there is a uniform sinus haziness in all the sinus, which is more commonly in frontal sinus, and there is frontal loss of frontal hostra. Then we can see in the second X-ray, the entire maxillary, right maxillary has gone, and it is in contact with the eye orbital shadow. Then on the third side, we have osteomas of the frontal lobe. CT scan which shows haziness or density lesions in the maxillary sinus area is the axial. MRI scan will show the same signal intensity, but little bit uptake will be more. What are the reasons for using CT and an MRI? CT, the cost is cheaper than MRI. The details of bony structures provides good details about the bony structures, less details compared to the CT scan. Imaging ability to change the imaging plane with improving, moving there. So we have radiation exposure, which is very high in case of CT scan, which is none in case of MRI. The principle used for imaging is X-rays for CT scan, magnetic and radio waves to create the images in case of MRI. Time take is usually 5 minutes, which is almost around 30 minutes in case of MRI. Details of soft tissue, less detail compared to the MRI, much higher detail in the soft tissues. Okay. The scoring system used for rhinosinusitis diagnosis is London Mackay system. So we have right and left and the maxillary, anterior rhythmites, posterior rhythmites, sphenoid, and the frontal. So if the score is 0, there is no abnormality. If there is 1, there is partial opacification. If there is 2, there is complete opacification. For the osteometal complex, if 0, no, not occluded osteometal complex. If it is 1, it is occluded. Diagnosis of chronic rhinosinusitis suggested by the history. Then we can go for sinonasal endoscopy. For normal endoscopy, we have then we can go for CT scan. If CT scan is normal, consider other diagnosis. Suppose if the CT scan is positive, then you have to go for initiate treatment of allergy and evaluation of allergy if not done. Okay, this is what is the algorithm. Suppose if there is some positive endoscopy, then initiate treatment for allergy, then allergy evaluation has to be done. Suppose if there is purulence, then we have to culture it. If there is a polyp, we have to go for polyp algorithm. Medical management aims to reduce the signs and symptoms, improve the quality of life, and prevent disease progression. So how to avoid this one? Allergy is the predominant etiology for development of rhinosinusitis. So we have to go for allergen avoidance, irritant avoidance, and nasal douching. Nasal douching is beneficial in the way it clears off the secretions and materials in the sinonasal mucosa and reverts this mucosa. This is by nasal douching. Corticosteroids, we have two forms of corticosteroids. One is topical, the other one is systemic. Based on the steroidal potency, the corticosteroids are graded into mometasone, fluoride mometasone. The dose per day is more than less than 50 micrograms per day. Then we have fluticasone, which is approximating almost to 50 microgram. Then budesonide. Budesonide can be used for a period of 32 micrograms. Flunisolide, which is again used duration can be more than 6 weeks. Then triamcinolone and acetate, dose per day is 55 micrograms. Beclomethasone, we have a dose per day is 84 micrograms. This is the steroidal potency ladder and how much is the availability of the same. Then we can go for otrivin or xylometazoline nasal decongestant. We have pseudoephedrine hydrochloride drops and adrenaline and oxymetazoline, xylometazoline. These are decongestants available. Then antibiotics topical underexplored. Beclomethasone drops plus neomycin has worked out well. Then tobramycin in cystic fibrosis. Topical antimicrobials in the management of chronic rhinosinusitis. Systemic review was done in American Journal of Rhinology in the year 2008. Nebulized bacitracin and colimicin. Okay. Oral short course of treatment, we can give amoxicillin with clavulanic acid or cefuroxime or erythromycin 200 to 15, so 200 to 250 to 500 milligrams 6 hourly. On long-term prophylaxis, we can go for macrolides. This reduces the bacterial load by decreasing the addition, decreasing the virulence of the organism. They also inhibit the toxin and dye production. They also destruct the biofilm. On the cause, there is modulation of the defense mechanism. There is increased monocyte, so there is increased macrophages, inhibits cytokine production and inhibits neutrophil function, decreases mucus production and inhibits the chloride channels, decreases glyconjugate secretion, increase ciliary beat frequency and increase the steroid receptors. Antifungals, we have amphotericin B, terbinafine and itraconazole. Antihistamines, we can use either fexofenadine 120 to 180 milligram oral, loratadine or desflurane. Anti-leukotrienes, we have xylutan 600 milli tablet 4 times a day, or montelukast 10 milligram HS, or zafirlukast 10 milligram or 20 milligram once daily. Aspirin, we can go for oral aspirin, nasal aspirin, then lysine production, lysine aspirin, which reduces, leads to reduction in the retention in cystinoid kinase leukotriene receptor. Immunotherapy, we can go for immunoglobulin replacement therapy and bacterial vaccines. We can have other therapies like avoiding diet, high salicylate foods can be avoided, then milk products can be done. Diuretics, sodium channel blockers and amiloride, nitric oxide donors. Then surgical approaches. Highmore in the year 1651 described maxillary sinusitis and treatment by decompression using silver bodkin through empty tooth socket. It was John Hunter in the year 1835 who has done the intranasal approach. Sucrandal in the year 1893, middle meatal antrostomy, but later abandoned due to orbital complications. Then we have inferior meatus antrostomy, which was first described by Gooch in the year 1770. Cross in the year 1887 has used a needle, whereas McCullis in the year 1887 introduced the trocar, Lichwich trocar and cannula. The Lichwich, the name Lichwich was given from the person who has invented it, and Stilett invented the cannula. Canine fossa approach was described by Caldwell in the year 1983, Spicer in 1894, and Luke in the year 1897. Trephination is by Riedel in the year 1998. Lynch-Howard external procedure frontoethmoidectomy was described in the year 1921. These are the historical perspectives of surgeries for sinusitis. For the maxillary sinusitis, the conservative treatment would be antral lavage or antral washout, whereas the radical procedure would be Caldwell-Look surgery. On the intranasal antrostomy, we have middle meatal antrostomy or inferior meatal antrostomy. Frontoethmoid draft type 1 to type 3, endonasal drainage, trephination of the frontal sinus or sphenoid, intranasal ethmoidectomy, functional endoscopic sinus surgery, then transantral ethmoidectomy, Jensen and Horgan. Antral lavage indications are: it is diagnostic, acute maxillary sinus which failed to respond to medical treatment, external drainage in orbital complications. Inferior meatal antrostomy indications traditionally used in acute and recurrent acute or chronic sinusitis. In cystic fibrosis, primary ciliary dyskinesia. Contraindications will be polypoidal hypertrophy of the turbinates, presence of osteitis, and suspicion of malignancy. Suppose if this intranasal antrostomy is extended too posteriorly, may injure the inferior meatal wall of the lateral sphenopalatine artery. Anterior extension may damage the branch of superior alveolar nerves and alter dental sensation, damage to the nasolacrimal duct, which can be seen it in the diagram where there is damage to the anterior structure, and this is how the CT picture will look like after completion of this surgical trephination. Caldwell-Look approach, sublabial approach to the maxillary sinus through the canine fossa, wherein the maxillary mucosa is radically excised and drainage is established by creating a intranasal antrostomy. Indications: chronic maxillary sinus with irreversible mucosal changes, recurrent antrocanal polyp in patients more than 18 years old, removal of benign tumors, approach for video neurectomy, approach to maxillary maxillary artery ligation, invasive fungal sinusitis, chemoantrum, and blowout fracture of the orbit. Technique: incision, elevation of the flap, sublabial flap, opening of the antrum near the root of second molar, dealing with the pathology, making a nasoantral window, packing of the same, then closure of the wound. This is a diagrammatic representation showing the Caldwell-Look technique. External ethmoidectomy indications are orbital complications such as subperiosteal abscess. Technique: torsorrhaphy, gull wing incision, the lateral elevation of the lacrimal sac, elevation of the periosteum, and closure of the incision in 2 layers. External frontoethmoidectomy indication: removal of tumors, frontal or ethmoidal mucosils, and orbital complications. Technique: we can go for torsorrhaphy, then incision similar to external ethmoidectomy, except the incision is extended superior over to the rim of the eyebrow. Lateral dissection of the lacrimal sac, ligation of the anterior ethmoidal artery, exposure of the entire lateral wall of the ethmoidal complex on the inferior wall of the frontal sinus, drilling on the inferior wall. Then we place a elastic stent, close the layer with 2 layers. Complications of ethmoidectomy: injury to the trochlea, injury to the medial rectus, blindness, exposure keratitis, corneal abrasion, skull base injury, or sometimes if there is ethmoidal labyrinth injury, it leads to ESF leak. Frontal sinus trephined indication in revision surgery with endoscopic approach. Acute frontal sinusitis unresponsive to medical treatment. Endoscopic sinus surgery, the indications are chronic the FIS is the gold standard treatment these days. Indications are chronic rhinosinusitis, acute recurrent rhinosinusitis, nasal polyposis, mucosils, allergic fungal sinusitis, mycetomas, repair of the CSF leak, orbital and optic nerve decompression, repair of the blowout fracture of the orbit, dacryocysto-rhinostomy, choanal atresia, and hypophysectomy, septal and turbinate surgery. Principle of FIS: preservation or at least approximation of the normal bony superstructure, preservation of the mucosal texture as much as possible. Contraindications: intracranial complications of acute infection, cavernous sinus thrombosis, some revision surgeries. Usually it is done under local or general anesthesia. Steps: we have infiltration, uncinectomy, middle meatal antrostomy, frontal recess clearance, anterior ethmoidectomy, posterior ethmoidectomy, and sphenoidectomy are done if it is indicated, only if it is warranted. Complications: Synechiae formation, injury to the nasolacrimal duct, epistaxis, anosmia or hyposmia, pain, asthma, dry eyes, transient pupillary dilatation or ocular motility changes. Major complications include fatality, internal carotid artery injury, brain injury, blindness, and CSF leak. So this is the treatment algorithm for a patient with chronic rhinosinusitis without polyposis. Mild disease, you can go for intranasal corticosteroid for a period of 6 to 8 weeks. Allergy evaluation if it is not done. If there is good response, you can continue to maintain therapy. Then you can go for endoscopic sinus surgery at a later date if need be. Suppose if there is a poor response after allergy after intranasal corticosteroids, then you have to go for treat it as mild to moderate disease, or in this we can give for antibiotics for 3 weeks duration, short course of peroral steroids, intranasal corticosteroids again for 6 to 8 weeks, saline irrigation, leukotriene modulator, as well as allergy evaluation. If there is good response, you can go for maintenance therapy. If there is poor response, then you have to go for CT scanning. If the CT scan is suggestive of positivity, you can go for endoscopic sinus surgery. Normal CT scan, then you have to rule out other possibilities rather than sinusitis. Treatment of chronic sinusitis with polyposis. We can go for intranasal corticosteroids for a period of 6 to 8 weeks, broad spectrum antibiotics. If there is treatment is good, you can go for maintenance therapy. Suppose if there is poor response, then update CT. Then based on that, we can go for either endoscopic sinus surgery or other diagnosis. Okay. So this is the treatment algorithm for CRS with polyposis. Complications: extracranial and intracranial complication. Extracranial, we have cellulitis of the face, mucosal of the frontal sinus, abscess over the face, orbital cellulitis, osteomyelitis, and septic focus. Whereas on the intracranial side, we have meningitis, encephalitis, brain abscess, and cavernous sinus thrombosis. Mucocele, it is an epithelial lined mucus containing sac completely filling the sinus and capable of expansion. The frontoethmoidal mucocele is seen in 89%, ethmoids 8%, sphenoid 2%, and maxilla 1%. Etiology: infection plays a dominant role, which is somewhere around 23%, polyps 21%, and trauma 11%. Theories for mucosal formation is usually due to pressure erosion, then cystic generation of the glandular tissue, then active bone resorption and regeneration, osteoblastic as well as osteoclastic activity. Osteogenesis are normal. There will be osteoclastic and osteoblastic activity. This osteoblastic activity is seen as the reason for this development of chronic sinusitis. Clinical features: proptosis is seen in 91%, then diplopia in 95%. Imaging techniques shows the mucoceles. Treatment: endoscopic endonasal approach, combined endoscopic and external approach. Moving on to the advanced terms, we have image guided surgery. Image guided surgery is used of real-time correlation of the operative field to a preoperative imaging data set that reflects the precise location of the selected surgical instrument to the surrounding anatomic structure. Primarily for neurosurgery, but now for endoscopic sinus surgery also. It has a computer workstation which has Unix system, then Windows system, image processing of the software, display monitor will be there, where localization can be done with the use of optical tracking or electromagnetic tracking. Then with specialized instrument, we can remove the concerned parts. So you have preoperative evaluation, spiral CT acquisition, registration, testing accuracy, and procedure. Uses of image guided sinus surgery: we have revision sinus surgery, distorted sinus anatomy, extensive sinonasal polyposis, pathology involving the frontal, posterior ethmoids, and the this one, disease abutting the skull base, CS of rhinorrhea, benign and malignant neoplasms. A word about the bacterial biofilm. Biofilm is a structure community of cells enclosed in self-produced polymeric matrix and adherent to inert living surface. May be made up of fungal or bacterial cells that communicate with one another in a cooperative manner. Matrix, it is containing of polysaccharides, nucleic acids, and proteins. Biofilms has quorum sensing. Different susceptibility to different antibiotics. Mechanism include polysaccharide coat, slow to allow and incomplete this one, deactivation or neutralization, then non-growing state, it is to fewer prions. So once the biofilm has formed, it leads to initial attachment, irreversible attachment, maturation, then dispersion. So this is the reason for the development of resistance in the treating a patient with chronic rhinosinusitis. So this biofilm leads to special molecule targets of the biofilm life cycle, interrupting the attachment phase by disrupting the type 4 pili of the Pseudomonas. So a word about superantigens. The superantigens are class of antigens which causes non-specific activation of T cells, resulting in polyclonal T cell activation and massive cytokine release. Can produce virus, mycoplasms, and bacteria. Compared to the normal antigens, it produces response in 0.1 to 0.0001% in normally activated. They are stable, resistant to heat, and they are very much proteolytic in digestion. Thank you all for patient listening. This finishes the class with respect to chronic rhinosinusitis and its management. Thank you.